Okay, so, all right. Okay, so today I wanted to talk about pediatric obstructive sleep apnea and tagging on the words beyond T&A. But we got to start somewhere, and I think starting with the tonsils and basic review is probably a good foundation. And so let's see, this is a little guy with obstructive sleep apnea. I know you can't hear much, but he's struggling for breath. And sometimes you could get parents to show you videos of the kids, and those are highly suggestive. So today, just wanted to give you a basic on pediatric obstructive sleep apnea, maybe cover some reasons for tonsillectomy failure, and then consider some other management options, including both surgical and non-surgical treatment of pediatric obstructive sleep apnea. So 3 components make up the pathology of OSA, and it includes episodic hypoxia, oxygen desaturations, hypercarbia, which we see a lot more in children than adults, and sleep fragmentation, which actually is something that will make adults very sleepy. It's broken sleep. So there's no consensus on definitions. For the adult, the apnea-hypopnea index greater than 5, some have used it in children. You'll see some things written about AHI greater than 2 or the apnea index greater than 1. So it's all over the place. Mostly people will agree on minimum oxygen saturation less than 92%, although we look at it as less than 88% as well. And then hypoventilation has a diagnosis if the carbon dioxide is greater than 25% of the night. So we typically will rely on the standard research definition, which means between 1 and 5 obstructions per hour is mild, 5 to 10 is moderate, and greater than 10 obstructions an hour is considered severe in children. Although this gets kind of cloudy when you get into the upper adolescent age groups. And so again, there's no consensus, but with the preteen, this is fairly standard, I think. So with adults, an apnea is 10 seconds, but with children, and I think I mentioned this last time, that they measure what the breath cycle is, and that's how they score the study. So it's not measured in seconds like an adult. Secondly, you don't need a desaturation or an arousal for this. The normal apnea index in children by Carol Marcus was between 0.1 and 0.5, and then hypopnea is different in children. Adults, it's 4% reduction, that's Medicare, and in kids, 3% reduction in oxygen saturation, or an arousal. When you see a dip in airflow, you can either score the hypopnea with a oxygen desaturation or an arousal. You can use either, but in adults, an arousal is not included. And bottom line, it may be more significant because the respiratory rate is faster. That is, hypopneas may be more significant because we don't see apneas as much in children. So OSA affects maybe 1 to 4% of otherwise healthy kids, and can be associated with a number of symptoms, which we'll go into a little bit more detail later. Sleepiness, you don't see so much in children, more so in teenagers. Enuresis is secondary enuresis. They've been potty trained and then they start to wet their bed again. So you need to ask about that. Cardiovascular problems, not as big an issue in children, but poor growth, you'll see failure to thrive. Attention issues is a big thing. Many times ADHD is undiagnosed sleep apnea, as well as hyperactivity. And then you'll see academic difficulties. The bottom 20% of a class has a much higher number of kids with obstructive sleep apnea and sleep breathing disorders, and behavior concerns, of course. So snoring and labored breathing, you have to ask parents. Sometimes they won't tell you unless you ask them. Restless sleep, that's a big one. Kids are all over the bed, and you'll find them in unusual positions. And some parents will come out and tell you that the child will end up sleeping sitting up. I had one of these kids a couple of months ago. And then paradoxical breathing, seeing the chest and abdomen move against each other rather than at the same time. And then the enuresis we measure. But you got to ask about that. And I always ask in such a way that it doesn't embarrass the child. Then hyperactivity, daytime sleepiness we mentioned, poor growth. Growth hormone is released during stage 3 sleep, and that occurs primarily in the first 90 minutes of sleep. But if they have fragmented sleep, that can interfere with that. After treatment, such as tonsillectomy, you'll see kids catch up rapidly in growth, academic difficulties, cardiovascular problems. So you'll see either failure to thrive, they're really emaciated kids because they can't keep up with the nitrogen balance, or they're obese, and we're seeing a lot more of that now. I saw 2 kids this morning were obese. One was a BMI of 40, he was 7 years old. Nasal obstruction, just look for mouth breathing. Got their mouth open, they got adenoid facies, that can be an aggravating factor. And of course, big tonsils. The one kid this morning had overlapping tonsils. And sometimes the exam is totally normal. Like another little guy I saw this morning, I couldn't find what was obstructing on him. So we're taking him to do drug-induced sleep endoscopy. So most of the kids have adenotonsillar hypertrophy, but you can't put the size of the tonsils and adenoids on equal proportion to OSA severity. So the severity of obstructive sleep apnea doesn't relate to the size of the tonsils and adenoids. And sometimes they appear normal in size, but they're causing significant obstruction. Or you'll see 2 kids, same body build, same 2+ size tonsils, but one has obstructive sleep apnea and the other doesn't. So more than just tonsil size. And then critical closing pressure. And I didn't change the abbreviation CCP. That was an incorrect abbreviation. It should be P and then sub letters CRIT, critical closing pressure. And if the tension of the tissue is strong enough, they're not going to obstruct. We mentioned this when talking about adults. So I'm sorry, I missed some of my footnotes here, but the quality of life is significantly worse in a child that has obstructive sleep apnea, and the quality of life is often underestimated. They've done QOL surveys, and they found that the OSA kids are probably equivalent to other chronic conditions such as rheumatoid arthritis and asthma. And dramatic improvement occurs in these domains after tonsillectomy and adenoidectomy. So again, severity of OSA, as we said, doesn't matter with tonsil size. It also doesn't matter in its effect on quality of life. You can have mild, moderate, or severe OSA, but the difference in severity is insignificant. They can all impact quality of life. And can be dramatic when you treat it, whether it's mild or severe, that they have a dramatic improvement in behavior or other quality of life issues. So that's why we say that treatment is imperative in these kids for maximizing their development and overall health. And tonsillectomy with adenoidectomy is first-line therapy for OSA and sleep-disordered breathing. Comment on sleep-disordered breathing. Primary snoring is not necessarily obstructive sleep apnea, but it can impair child learning and behavior. Now, with tonsillectomy and adenoidectomy, it does cure most kids, but 10 to 20% of otherwise normal kids have residual obstructive sleep apnea. So, clinical practice guidelines from the American Academy of Pediatrics. All children and adolescents should be screened for snoring. So he asked the question. And then PSG or polysomnogram performed in those kids where they have both snoring and symptoms or signs of obstructive sleep apnea. And again, we can talk about learning difficulties, behavioral problems as one of the signs. And then when you're asking about snoring, the 3 times a week seems to be a key that many studies will go on. And that's actually in one of our questionnaires. Are they snoring more than 3 times a week? Do they snore nightly? That's generally more indicative that they may have a problem with obstructive sleep apnea. And then asking parents about labored breathing. We talked about getting the parents to video the kids. Some parents will bring that in and show it to you, or they'll just have a recording because they don't know they could turn on the light and video the kid while he's sleeping. Daytime sleepiness, more with teenagers, but you got to watch with teens sometimes because they'll not go to sleep till 1 in the morning because they're dealing with their computer or their phone under the covers. Learning problems, observed apneas, and there can be pauses in breathing. Some parents will describe just pauses. Others will describe snorting or gasps, or even demo the sound to you. And then sleep enuresis. Again, we're talking secondary enuresis once they've been potty trained. And I have a handful of kids that come in with 10, 12 years old with bedwetting, and they're very upset about that. So how do we treat pediatric obstructive sleep apnea? Again, tonsillectomy, adenoidectomy, first-line treatment for those with adenotonsillar hypertrophy. It used to be, before we knew what we knew now, is that all kids got tonsillectomy and adenoidectomy. And then when they didn't get better, you treated with CPAP. But that was not too long ago, actually. And then high-risk patients, you consider them as inpatients. Insurance and your hospital may tell them they're outpatients, but an overnight observation would be recommended, such as very obese kids, maybe kids with asthma or seizure, severe obstructive sleep apnea, and perhaps Downs kids or kids under age 3, because there can be respiratory problems postoperatively. And so the effect is pretty large in most cases, and parents will think you're a godsend. But sometimes they'll say there's improvement, but it's incomplete. Pulmonary hypertension probably is a little bit overrated for children. Growth biomarkers, we talked about growth hormone secretion in stage 3 sleep in the first 90 minutes, but you'll see them catch up to their fellow children. So, but the resolution is not as great as we used to think. There's more a greater percent of residual obstructive sleep apnea than we used to think. We used to think T&A would cure it, but maybe in 85%, it seems to in otherwise healthy kids. You throw in a couple of comorbidities and that goes down. So Mitchell out of Dallas, I like this little slide. He looked at the definition of obstructive sleep apnea. We talked about that a little earlier, whether it's greater than 5 obstructions an hour like an adult, or is it greater than 2? Some papers will say 1.5, some will say greater than 1. So when you look at this, you'll see that maybe 84% normalize if you're using 5 obstructions an hour as a bottom line, and you'll get less improvement, 71% in his study, if you're using AHI greater than 2. So the stricter you get on definition, the less normal you get. You got to keep that in mind when you're reading the papers. So summary of this section is that obstructive sleep apnea is associated with behavioral problems in children. Quality of life is similar to other chronic illnesses such as rheumatoid arthritis or asthma, and that adenotonsillectomy can provide great improvement in all these things. And quality of life and behavior are independent of the severity of obstructive sleep apnea. That is, you can have severe behavior issues with mild obstructive sleep apnea and so forth. So tonsils are not the sole cause of childhood obstructive sleep apnea. We do have residual OSA in these kids. So again, for the clinical practice guideline, patients should be reevaluated postoperatively to see if further treatment is necessary. And some parents will say they've got their child back, they're normal again. But you know, you need to look at some behavioral issues too, and sometimes they improve partially, so they may or may not be totally related to obstructive sleep apnea. They may still be restless in bed, and I'll look at reevaluation if they have significant comorbidities such as obesity, seizure disorder, Down syndrome perhaps. Because parents can't always tell that obstructive sleep apnea is gone. So again, high risk factors, obesity, asthma. For some reason, asthma is a risk factor. I think I mentioned last time that we have one of our pediatric pulmonary colleagues looking at that with me right now. And then the kids that have small tonsils or adenoids can have a perhaps higher risk of residual OSA, and certainly craniofacial abnormalities. So for some reason, there's residual disease if the age is greater than 7 as well. That seems to be a big influence. And again, non-obese with asthma, question why that might be. And then non-obese with severe OSA, so they tend to have residual. So one of the kids this morning post-op, his pre-op AHI was 20.8, and post-operatively it was 2.1. But he didn't seem to have a whole lot of residual issues. He had other sleep concerns for which he was seeing another sleep physician, non-surgeon. And so he's going to come back if the sleep physician, pediatric sleep physician, feels that surgery is indicated. So, diagnosis of obstructive sleep apnea children. And that's the Naval Hospital in Guam when I was stationed there in that remote Pacific island. Actually, it was built in the late 50s to be a 500-bed hospital, but when I was there, it was only a 60-bed hospital. So, history and physical cannot differentiate between snoring and obstructive sleep apnea. Signs and symptoms don't reflect severity of disease. I think you're kind of hearing that enough times by now. And then the ability to distinguish it by history is extremely poor. Studies have shown this. And you can't really predict which kid is going to have obstructive sleep apnea. So if they have signs, symptoms suggesting it, then a sleep study is indicated. And talk about other techniques are useful if positive. That's not something most people will depend on. There's high false negative rates. For instance, video has a correlation with the PSG 84% of the time, and home oximetry, which is really poor, not recommended, but sometimes on low functioning Downs or other neuromuscular kids who don't cooperate, home oximetry may be all that you have. And if it's positive, well, then you have to go with it. But if it's negative, you can't rule it out with these. So the reason that it's a diagnostic test of choice is because you confirm the diagnosis of OSA with it, and that'll justify whatever treatment you move on to. Also, it can provide you with differential of other sleep problems, such as periodic leg movement syndrome of sleep. And in kids, that can be related to a low serum ferritin below 50. And that can cause some of the related behavior problems from sleep. Then you can assess severity of sleep apnea, because the severe ones you want to maybe retest or keep them overnight for observation. Assess operative risk. If they have significantly low saturations, of course, you're going to want to assess those in-house postoperatively. And then you have a baseline for follow-up, whether you treat with medication or non-surgical treatment or surgical treatment. And again, pediatric sleep lab is preferred. The labs that don't see a lot of kids tend to have a harder time with it and perhaps less reliable. So overall, you're out in the field, private practice. If history correlates with exam, T&A. But then again, you don't have your assessment of severity. And snoring is not diagnostic of obstructive sleep apnea, but it can still affect the child in a negative way. And they can have, as you see in the third point there, as many neurocognitive issues as a child who has obstructive sleep apnea. And so the point was made, and I missed citing my reference here, the need to distinguish between these is questionable. So if the parents have concerns regarding sleep, but the exam looks otherwise normal, get a sleep study, because you don't want to miss this. Just like within hearing loss, 50% of kids with hearing loss are noted by the parents. 50% are missed, but if the parent thinks the kid has a hearing loss, you get an audiogram. Similar here. And then certainly if you're going to do tonsillectomy and adenoidectomy, if they have obesity, Downs, or any other significant comorbidity. And then post-op, if they're in a risk group, or continued symptoms. And some kids, you might get post-op pulse oximetry if they can't tolerate a PSG. So what if tonsillectomy fails? Well, you can consider CPAP. As a matter of fact, and I don't agree with this guideline, but they recommend continuous positive airway pressure in children if adenotonsillectomy fails, or if you don't perform it for whatever reason. And then weight loss is recommended, but I've never seen that to work in any of the kids that have come through our clinic. And parents just have to stop feeding the kids, but that doesn't happen, at least not here. And then intranasal corticosteroids, Flonase in kids, that's an option. And I've used that with mild OSA in young children when tonsils may not be as enlarged. And you give a four-month trial on, say, Flonase and Singular. Flonase can decrease AHI by as much as 4 points, and Singular will throw in an extra point sometimes. It's hit or miss. Some folks will come back and the parents will say the kid is normally stopped snoring, behavior is improved. Others will say they didn't see any change. And so with the younger ones especially, I like to try the Flonase first. The adenoids will start growing around age 3 in the average kid. And so between age 4 and 7 is when you really have an increase in adenoid and tonsil size. And so Friedman, there's two Friedmans in obstructive sleep apnea. This is Norman Friedman, and Michael Friedman's out of Chicago, and they're not related. So he feels that you should discuss all modes of intervention with the families instead of just kicking them into tonsillectomy or adenoidectomy. He says that he finds it very interesting or intriguing that CPAP is not offered universally, but considered only 50 to 89% of the time. That's in his studies. I don't see CPAP as a first choice for a kid unless they're significantly disabled or if parents have a real problem with surgery. But compliance in kids, pretty tough. In Dallas, Ron Mitchell has a very good track record for CPAP in kids. And so the way that they do it is all kids who fail CPAP or fail T&A go to CPAP, where in our state here in West Virginia, that's not going to work. So we look at surgical options before CPAP. And there's other reasons I have for that too. So we talked about weight loss, nasal steroids, and mild OSA. If they're on CPAP, which I don't expect that you would treat them with CPAP with an annual visit, but it's expected that you should repeat a PSG every year if they're on CPAP. Palate expander, that's your dental colleagues could put this in, and oral splints and dental appliances really need secondary teeth and then facial growth to be complete, because most orthodontists are not going to go for this just because they are fearful of changing facial shape and bite characteristics. So what about medications? Well, Medrol dose pack, no change. Nasal steroids, well, yeah, you can, here it says 3, and I don't have my reference, but can go up to 4 per hour. But as noted a few moments ago, tremendous variation. Sometimes you see a great improvement, other times you don't. And then a leukotriene modifier. You know, we pretty much have one singular. It's very safe. Sometimes there's some behavioral questions. I have seen that very rarely, but Dr. Carr probably seen it more than I have. And there are leukotriene receptors both in the adenoid and tonsil, as well as in the nasal tissues. And again, 16 weeks of daily use. And if parents say that the kids are resistant, I say wait until they're in a deep sleep and then just go ahead and put it into their nose. It's at least something. And some studies have shown a decrease in adenoid size, really no decrease in tonsil size that I've read about or seen. And oral appliance therapy, there's only a few studies on this in children. And the one study down below is 2002 or 2012, same person out of Italy. They talk about a mandibular advancement device, but the paper talks more about a palate expander. But it shows in either case that they do get improvement, and in their consideration, they're using it with jaw deformities. So a prospective study here, 31 children with rapid maxillary expansion, and they decrease nasal resistance in every case, and apnea-hypopnea index less than 1. I've made recommendations for the parents to talk to their dentist about this, and certainly can help quite a bit. The expansion is usually done within about 4 to 6 weeks' time, and then they keep the expander in place for 3 to 4 months. So these slides I borrowed from Casey Lee. He's out of Stanford, and fortunately I didn't ask him for it. I'm citing him. But you can see the mid-palatal suture expanding in the radiographs below, and you can see a widening of the high palatal arch. So nasal CPAP, 2006, they finally approved it for age greater than 7 or greater than 40 pounds. And for the young kids, they really got to mess around with the masks and make them fit. You need dedicated families, which sometimes are hard to come by now. And pressure is adjusted to disease severity to resolve the obstruction, so it's not according to age. And then again, success may be limited. Children sleep a lot longer than adults, and maybe 50–60% end up using it. But again, you see the mean nightly use is 5.3 hours, and kids spend 10 hours a night sleeping. So maybe it's not doing everything we would like it to do. And then parents, as well as adults on CPAP, always overestimate the use, even if they have good intentions. And then effectiveness, if they use it, actually it does work. But this is one of my big concerns, and I remember one time going back and forth with a pediatric pulmonologist who's no longer here, who said that he never heard of these studies. There were several studies. I just have one cited right here, 2005, where you get facial flattening and maxillary retrusion. So it actually can push the midface in and perhaps theoretically or perhaps for real, worsen the obstructive sleep apnea. And this more recent study was a retrospective study, again, coming out of our dental sleep colleagues, midfacial growth changes. And so this is my big concern. And then some of the other procedures that we do beyond tonsillectomy are maybe not as dangerous as some people fear. And kids tolerate them sometimes much better than traditional tonsillectomy. So this is just a second note on the 2016 study. So they had mean annual change or retrusion of the midface, and the control group showed that they had normal growth. So just to quote this study, ironically, midface retrusion may lead to more narrowed upper airway and potentially worsen obstructive sleep apnea that the CPAP's intended to correct. So what about bariatric surgery? In adolescents, you know, there was a survey, and again, I'm sorry I don't have the the citation for this, but showed that maybe there were 100 hospitals in the country performing adolescent bariatric surgery. This was, again, it's a little dated, but maybe 87% of them, most of these perform less than 4 a year. So that's not a lot of great experience. And then the paper that I cited there, they looked at it with BMI greater than 40 with comorbidities. And I think that's supposed to be without comorbidities, or BMI 35 with major comorbidities. And then when they did gastric banding, it worked better. And metabolic syndrome was seen in 40%, and actually metabolic syndrome resolved in a large number of these. But you need a motivated kid just like an adult, because you got to change your dietary habits. So what if obstructive sleep apnea persists after T&A? And well, again, H&P is insufficient. So you can do an in-office fiber optic looking for adenoid regrowth. A little bit harder to do on children, but you got a great teacher in Dr. Carr. And of course, you can consult sleep medicine for perhaps CPAP, or do an allergy evaluation and treatment. Orthodontics, of course, we talked about rapid maxillary expansion. Then craniofacial, of course. These are kids I really don't want to touch. I'm not trained to do that stuff, and I'm glad that we have those colleagues. So what are some reasons for failed T&A? And by the way, that's the Grand Canyon and the Colorado River down below there. Clinical diagnosis, surgical management. And I would say in the last 10 years, I've done a lot of post-T&A surgery for these kids. And why are some of these kids having it? Macroglossia, enlarged tongue. Sometimes they're born with enlarged tongue, and it could be Treacher-Collins or any one of those syndromes. Or it can be just the kid has a tongue that's too big for his mouth, or the jaws may be a little bit too small. We've seen both. And then laryngomalacia, which are different kinds. Lingual tonsil hypertrophy. This is a significant issue many times in Down syndrome cases. Down syndrome, the recommendation is for primary care, if you have a Down syndrome in your practice, by age 4, they should have a sleep study as a screen for sleep apnea. And then occlusal malproportions. So macroglossia, this is a drug-induced sleep endoscopy. And there you see the uvula lying on the base of the tongue. So this little guy has got too much tongue in his mouth, and it's sitting inside the airway. So it's going to an apnea. Now, the airway is smallest at the end expiration, so that's what you were seeing there. Well, what about laryngomalacia? You have the infantile or omega epiglottis, short area epiglottic folds, sometimes redundant arytenoid mucosa. This is a post-adenoidectomy, had a little residual there. And so look at the epiglottis. It's kind of folding in on itself. And there are different patterns of epiglottic obstruction. But this is kind of an omega epiglottis. There are different types of treatment that you would use for laryngomalacia. What about lingual tonsil hypertrophy? Well, lingual tonsils here, you're seeing they're almost bilobed, and they're pushing the epiglottis posteriorly against the posterior pharyngeal wall. And again, you're seeing the breaths during sleep endoscopy. And taking out or removing the lingual tonsils will many times allow that epiglottis to come back. Well, you have nasal obstruction. This was a Down syndrome kid who the resident that was doing the sleep endoscopy, you can see a little blood there, had done an adenoidectomy on this kid just the previous year. And this resident was a senior resident when I first started, so the senior residents wanted in on this. And he felt so bad that he did an adenoidectomy on this kid, and you can see it's 100% obstructing. And then he's got the bilobed lingual tonsils obstructing, and the epiglottis curling in on himself. And unfortunately, you know, we treated him, we got him better, and he came back at twice the size the next year. They just kept feeding this little guy. It was so sad. We finally had to put him on CPAP. And then obesity, 20% of this age group is overweight or obese. And so obstructive sleep apnea, 10% prevalence in obese kids. So it's more than twice, perhaps 3 times as the normal kid. And again, to just emphasize, postoperatively, maybe only 1 out of 4 normalize with a tonsillectomy. In Down syndrome, you've got many things going on. You've got the mid-face hypoplasia, the nasopharynx is narrow, tongues are large, you know that. Plus they have hypotonia, and so sometimes the obstructions that you fix don't always cure these little guys. And then small larynx and trachea. So, you know, they've got everything. And a reason for recurrence in obstructive sleep apnea, weight, of course, is one, but in adolescents. And they found in one study, again, I forgot to cite here, they had a 13% recurrence rate in 16-year-olds. So there's a growth spurt in male. They put on muscle, and they put it on in the tongue. And the tongue grows larger in the 12 to 16-year age group. And I think I showed you the anatomy of the tongue last time with the 3 growth areas, and the posterior one puts it on the quickest. Okay, what about surgical interventions beyond tonsillectomy and adenoidectomy? Are we doing okay on time? I think we are. So this is, okay. This is on my way to Beirut in the old days. Unfortunately, they're having more problems now. Surgical interventions, we can consider nasal surgery. Turbinate reduction is a very safe procedure for kids and can probably do a lot. One of the things you can do if they're very nasally obstructed during a sleep endoscopy is put a couple of drops of Afrin in the nose, decongest them, and see how that changes the obstructive pattern. Septoplasty, not something that I would do with kids. That sleep endoscopy you saw in the Down syndrome, we actually ended up doing a septoplasty with him, but we made the incision within the nose, and we did it endoscopically and just removed that large impacting spur, so that he did fairly well with it postoperatively. We didn't put splints in, and we did not. We're not able to examine him postoperatively at that time, but we did with a subsequent drug-induced sleep endoscopy. So lingual tonsillectomy, we mentioned posterior midline glossectomy, we'll talk about, and then the laryngoplasty is supraglottoplasty. And so nasal obstruction, this is that same little guy again with the impacted nasal obstruction. And so there's always concern for facial growth centers, and so he's an exception because I generally won't operate on a kid till they're about 16, when most of the growth centers have closed. And turbinates, again, easier to treat. And I used to do it more often with submucosal needle tip cautery, but now I'm using the radiofrequency probe for these kids, and they do very well with it. So turbinate reduction with radiofrequency probe, and you see big difference. This is immediate post-op, or immediate intra-op, and then this is turbinate reduction with submucosal cautery, and you can see big difference there. So lingual tonsillectomy, this is a Lindholm laryngoscope, so the kid's on suspension, and these are 2 different kids, and then starting the lingual tonsillectomy. You see a little bit of tongue right in this area here, but going after the linguals. And so this is, I think, a 1 minute 15-second video that you can use a EVAC 70 probe for arthrocare. And I inserted along the side. I usually put it on the left side of the Lindholm scope, bend the tip just a little bit, keep it well lubricated because it only works underwater. And this is normal time. This is not speeded up. And this is a resident doing it. And as the residents get more experience, it does go faster. And for most of the kids, they don't have a great degree of pain, and actually seems to hurt less in the majority of them than a regular traditional tonsillectomy. Unless you get into muscle, if you start getting into the tongue muscle, well, then the pain starts increasing. Well, what about posterior midline glossectomy? This is procedure. I just saw a kid back this morning I took care of about 3 weeks ago, and Dad said there was no problem post-operatively, and snoring has stopped, and all sleep symptoms are improved. So we're getting a post-op sleep study on him in another 6 weeks or so. But what we're talking about is midline incision in the back here. You can see the circumvallates here, a retraction suture, and then the red indicates the course of the lingual artery, and then the lingual nerve goes with the lingual artery. And this is the lingual or the hyoid branch of the lingual artery back here. So these are diagrams kind of demoing what you would do. And this is a photograph that we took here of the tongue as we start. So we put the suture in, and the resident who did this case is now an otologist with us here. Midline incision with electrocautery, stay sutures to hold the incision open. You can see some of the lingual tonsil in the back now as you're drawing the tongue forward. And then the EVAC 70 probe getting ready to ablate the tongue muscle and further ablation. And if you're in the center of the tongue, you're safe because there's no critical structures in the center of the tongue. Now, in the beginning, we take a sonogram Fushida probe, and we find the artery and we outline it in tissue markers so that we know where it is. And then sutures at the end, closing it anterior to the circumvallates right here, leaving it open posteriorly because you don't want it to collect fluid, enlarge the tongue, and give you an airway obstruction postoperatively. So you leave it open posteriorly for drainage. Okay, this is the actual procedure, and it is edited just so that we can get it shown to you in just the next few minutes. So you can see the marker on the side. Stay sutures holding the incision open. And it works underwater. And of course, you got to modify it to the size of the child. The child I saw this morning was a 3-year-old, but you know, we do all age groups if we find this is the problem. And simultaneously, if they have large lingual tonsils, you can depress the tongue without suspending them and get some of the lingual tonsil as well. Now, I put sutures in. Stacy Ishman out of Cincinnati says she doesn't because they always come out, but I've only seen that happen in 1 or 2 kids. So I've put vicryls in. So what about Laryngomalacia? Well, you got to figure out what the cause is, and you do that with sleep endoscopy. Dr. Carr is a great teacher. She'll tell you all about this stuff. So you can have hyperplastic mucosa on the left, and then you would trim that. You could have short AE folds here on the right, so you can size that. Very straightforward operation. And you know, as resident, you would mark this down as pediatric airway because you've got to meet your clinical indicators. And then posterior displacement of the epiglottis, epiglottoplasty. And there's different ways that you can do that. So this one paper talked about 3 types of laryngomalacia: the redundant mucosa of the area of the arytenoids, and then you have the epiglottis can sometimes bend into the airway. And type 3, he used laser. I don't use laser. I use the radio frequency. I think there's less risk with it, and it's easier to use. Plus, it's faster because you don't need a laser nurse or the setup time. And then epiglottopexies, when you're actually suturing up the epiglottis to the tongue base. Okay, so this is a drug-induced sleep endoscopy. It's So that's with chin lift, looking at the lingual tonsils, and see the short AE folds on the chin lift. And then you've got a little bit of excess mucosa on the arytenoids. So redundant mucosa of the arytenoids. Let's see, this is the video here. And this is a different patient. These are just photographs rather than videos. So these are sites where you would trim or excise excess tissue. And this is to illustrate that the epiglottis was the site of snoring in this child. There are probably 6 sites of snoring in individuals. The palate uvula is probably the most common. Sometimes it's the tongue base, sometimes epiglottis will do that. And so with epiglottic obstruction, again, these are photographs. I just wanted to illustrate these in a different way. And see the space behind the epiglottis is pretty open. Here there's tonsils, but they weren't obstructing. They're kind of impacting the airway somewhat. But if you took the tonsils out, sometimes the tongue can fall back. That's something I'm trying to look at right now. We published a paper on that with about a dozen or so children. So laryngoplasty or epiglotopexy, the minimal thing you can do is demucosalize this area, and with a co-blader with radiofrequency, as you're doing it, sometimes it'll just pull the epiglottis back by itself, and it'll hold it in place there. Now, supraglottoplasty, this is incising the AE folds, and then taking down some of the excess mucosa. I'll show you the video here in a minute, suturing the epiglottis to the tongue base. All done through a lintome for the most part, tying the suture, knot, and then the epiglottis is tacked up. So this is about a minute or a minute and a half video. Sometimes you see a little blood, sometimes you don't see any. I like to put a little palette or pledget of epi on there just to decrease this. And if you go a little bit too deep, you might see a little bleeding. There's the co-blader, reducing some of the excess tissue on the epiglottis, so it's not folding in on itself so much. And then demucosalizing the lingual surface of the epiglottis here. The lingual tonsillectomy is already done. If you try to put sutures through the lingual tonsils, it doesn't really hold very well. And then this is a 13 millimeter needle with a 4-0 vicryl suture on it. Initially, I was using chromic, but didn't seem to hold so long. This might be the video of the chromic suture early on, so it's a long time ago. And then through the tongue base. This is when I was using cup forceps to do it before we had the actual endoscopic needle holder for microlaryngeal surgery. And I have a little epi pledget sitting down there when the AE folds were incised. And then laryngoplasty, just showing that some of the arytenoids are trimmed off here, and then up at the top where it was curved, trimming some of that off as well. Shortened folds, and then incising them. And co-blading the excess arytenoid tissue. Dr. Carr, I'm sure, does it a little bit different. I sometimes incise it with microlaryngeal scissors, lingual tonsil hypertrophy, and then post-ablation. And there's a little suture knot in there with the epiglotopexy. So UPPP in kids, not real common. I've probably done about 6 or 8, and I've been very cautious. Pillar closure, trimming the uvula seems to be good in many of these kids. And then tongue suspension, I don't have any experience in children. RF tongue reduction, I've not done that in kids yet, and certainly not a genioglossus advancement. I send those to my craniofacial colleagues. Hyoid suspension, not going to do that in a kid, or sliding genioplasty. Mandibular distraction, again, our craniofacial colleagues. So, tonsils are not the sole cause of childhood obstructive sleep apnea. The severity of OSA is not proportional to the size of the tonsils. Removing the tonsils doesn't treat the problem 100%. Resolution may be in 70–80%, a little bit higher if the kids are totally healthy. And then to consider confirmation with a postoperative PSG if there are symptoms, risk groups, or other factors that are involved. So when they fail tonsillectomy and adenoidectomy, you can do a full exam with a flexible laryngoscopy. Imaging, I don't do imaging in kids, but Cincinnati is really into that. And then allergy evaluation, sometimes medical treatment with steroids, orthodontics or rapid maxillary advancement or expansion, oral appliances, question mark. Sleep endoscopy, do a lot of these, and it leads to a variety of surgeries. CPAP when other things fail, and sometimes we do that. I haven't sent any kids for obesity surgery. I leave that to their family doctors to do that. So that kind of concludes today's presentation. Does anybody have questions today?
Thanks, Dr. Coutras. What's the youngest you'll do a PSG in someone? Because sometimes we get pushback.
Well, usually if they're 2 years old, you know, and I highly suspect they'll have sleep apnea, I'll send them. Younger than that, I'll let my pediatric ENT colleagues make the judgment on that. But if they do it, they'll do it in the hospital for the younger ones. We're set up to do that here. Other questions? Okay, well, hope this was helpful to you, give you a little bit wider range of things to think about. All right.
All right, thank you so much.
Yeah, thank you.
All right, guys. Okay, take care now. Be good.